Well, welcome everyone. I'm so happy to see all these awesome faces here. We're so happy to have you. My name's Roberta. I'm the president of the Alagille Syndrome Alliance, and on the line you also have Cher Bork, who's the executive director of the Alagille Syndrome Alliance, and also Julia Bird. She is a director with the Alliance. And this Zoom is for Alagille and Transplant. And we have so many families that are dealing with transplant or heading towards transplant or are in post-transplant right now. So we're really excited to be able to pull this together. The Alagille Syndrome Alliance has done this in partnership with the parent organization of Split. And I'd like to introduce Jen Lau to give us a little brief intro to this group, and then she's going to go ahead and introduce our amazing guest speakers today.
Hi everyone. Thanks, Roberta. I'm very happy to be a part of this. So I am from the Patient and Families Engaged Partners of Split, and basically our group is comprised of patients and families that represent their Perspective Center in the United States and in Canada. And our goal as a group is to help provide our families hope through resources, support, and advocacy. And so we're very excited today to be able to have this for you guys and to give you the transplant perspective of your liver disease. I am very honored today to introduce our physicians panel. First, I'd like to introduce Dr. Evelyn Hsu, who's the Medical Director, Liver Transplantation Program at Seattle Children's Hospital. Dr. Elizabeth Rand, Medical Director of Liver Transplant Program at Children's Hospital of Philadelphia. Dr. Binita Kamath, Staff Physician, Division of Gastroenterology, Hepatology, and Nutrition at Hospital for Sick Children. And then Dr. Ricardo Superina, Head of Transplant Surgery at Ann and Robert H. Lurie Children's Hospital of Chicago. I would like to thank each of you for taking the time to be with us today, and we are all really looking forward to hearing what you have to say.
Mm-hmm. Thank you so much. Dr. Superina, are you here? Okay, we'll jump in. First of all, Dr. Kamath, would you give us an intro on Alagille syndrome?
Certainly, Roberto. Good afternoon, everybody. My guess is that this is a very educated audience already about Alagille syndrome, and we really wanted to spend most of the time talking about transplant, but just in case, just literally a 2-minute overview. So as most of us know, Alagille syndrome is an inherited condition, and it affects up to about 7 different organ systems in the body. And most relevant for transplant, the discussion today, as we know, that typically involves the liver and then other organ systems such as the heart, the kidneys, and then skeletal features. We know that there are facial features, which are very relevant to what we're going to talk about. And particularly when we consider the heart and the kidney, these are issues that we take into account both when we're evaluating a patient for transplant and in the post-transplant period. I think the other important thing to think about are the blood vessels that are affected in Alagille syndrome. We know that there are incidences of stroke or even just the finding of blood vessel abnormalities both in the brain and in other parts of the body. And when we're talking about blood vessel abnormalities in the abdomen, that can also have an impact on transplant. So I think that Alagille syndrome poses unique challenges for transplant because it doesn't just affect the liver. And I think that's what our very interesting discussion is going to be about today.
Mm-hmm. Dr. Superina had some slides. While he's not here, I do have his slides. Will one of you want to read off of those? Let me pull them up here. Okay, so Dr. Superina was going to talk about the genetics and organs affected other than the liver, non-transplant strategies, and symptoms like pruritus, jaundice, and xanthomas.
Do you think we should maybe wait to see if he
Yeah.
comes?
Sure, we can do that, or we can
Or
skip down.
that, or, I mean, certainly any of us could, you
Sure.
know, Dr. is certainly well qualified to run through these slides.
We can go on down. Why do Alagille patients need a transplant?
Yeah.
Binita.
Yeah, I think that's a good thing. I think all three of us could probably talk about that. I mean, so what are the, you know, we've given an overview, but what are the typical reasons that a patient with Alagille syndrome ends up needing a transplant? I'm sure Dr. Hsu, Dr. Rand, well, since Dr. Rand trained both Dr. Hsu and myself, I know that she knows because she told us. But I think that just to, you know, many of the reasons, certainly when kids are young, it's usually due to cholestasis. So by cholestasis, we mean a buildup of bile in the body, right? Buildup of bile in the liver. And so that leads to secondary complications such as intense pruritus, which many of you are familiar with, xanthomas, and then complications of those, such as, well, the pruritus being unremitting, but we can also see fractures, we can see the xanthomas be disfiguring, they can interfere with development. And so really what we're talking about in the early years are lots of complications of cholestasis. And then along with that, not absorbing fat from the diet, not absorbing calories from the diet, not getting enough vitamins, and therefore impaired growth. So that's sort of like a constellation of features early on. I don't know if Dr. Hsu or Dr. Rand would like to add to that.
I think that's a great overview. It seems to me that kids with Alagille syndrome sort of fall into two categories for why they need liver transplant. And one are complications of cholestasis, like Dr. Kamath just mentioned. Another category is sort of, as cholestasis progresses, you can actually end up with liver failure, and then anybody would need a liver transplant. Some children, though, have complications of cholestasis that, while they're not life-threatening, are really horrifically life-altering, such as the itching or recurrent fractures, for example. And those are absolutely legitimate reasons to have a liver transplant. And then finally, some kids, even if their cholestasis resolves in childhood, they'll have a lot of scarring in their liver, and ultimately that scarring will result in complications of high blood pressure in the abdomen, what's called portal hypertension. And then you may have a development of varices in the esophagus and bleeding, ascites, other complications that are more typical of cirrhosis rather than of Alagille syndrome in particular. So I guess actually that was three categories, but that pretty much those are pretty much the reasons that a person would need a transplant.
I'd like to actually, I think, pick up on what Dr. Rand said. We recently did a research study from the Children Network. Well, many of you will have heard of this network. It's a group of about 14 liver centers that have come together to study cholestatic diseases, of which Alagille syndrome is one. We looked at almost 300 children that had some type of liver disease and looked at how and when they came to transplant. And just to say that the data supports what we're saying, most of the transplants are in the early years related to cholestasis and complications of cholestasis, but there is almost this second group that happens later on, often when the cholestasis seems to settle, where you see, just as Dr. Rand said, you see the onset of portal hypertension. And we could see that in the research study that patients' platelet counts were dropping, and that's a sign in the blood work that's associated with portal hypertension. So even though many of these patients' cholestasis improved in the first few years of life, there's the second wave of patients needing a transplant later on. And by later on, I mean around the age of 6 to 12 to 15.
Yeah, but many children will have resolution of the cholestasis in their preschool or early school years and not have scarring and portal hypertension and will never need a liver transplant. And that's probably the majority, maybe even the vast majority, depending on who you consider to be people with Alagille syndrome. So obviously a child that was jaundiced as an infant and got the diagnosis has Alagille, but then oftentimes we uncovered that there's a parent who never knew that he or she had Alagille. And if you consider all of them, really many more people don't have liver transplants than do. The other thing that sometimes comes up is I've seen a lot of kids where the question is more, why do they not need a transplant than why do they need the transplant? Because some transplant centers, if they see a jaundiced child, they're like, oh, they need a liver transplant. But not everybody with jaundice needs to have a liver transplant. And if your quality of life is good and you're growing, then you're better off not having one. It's always better not to have it than to have it unless you're sick. So I think that's an important question as well. So if a child is grown happy, then even if they're a little yellow or have some xanthomas, we can probably let it be until such time as they need one, or maybe they don't ever need one. And then I guess there's a thing here, is transplant a cure for Alagille? Well, it's a cure for the liver disease. It's not a cure for the rest of the manifestations of Alagille. And of course, when you have a liver transplant, you have some new liver problems that are specific to transplant and no longer specific to Alagille. So it might be a cure for one thing, but it's a little bit more of a trade. But it's a trade for what we think is something better, or else we wouldn't want to do it. I mean, really, for most people that have a liver transplant, their problems that they have from their liver are solved, and the liver transplant will restore health and pretty much normal quality of life. That's why we want to do it.
Mm-hmm. Dr. Hsu, could you tell us about the transplant process, the UNOS list, the PELD score, all of the details that are so very difficult to understand if you're facing transplant?
Sure, and they're difficult to understand even sometimes when you're in it and doing it. So I think, you know, it's, and this pertains only to the United States allocation system, what I would be speaking on, but also speaking to a little bit of the context. So like when we come into transplant, if livers grew on trees, you know, it wouldn't matter. There wouldn't need to be rules about, you know, who got this scarce resource that a lot of people are competing for. But because they don't, there needs to be a set of rules in place. And no matter where you are in the world, there are different places where you do transplantation where they have their own sets of rules. And those rules are, you know, sometimes governed by universal ethical principles, and sometimes, you know, governed by kind of how much advocacy, you know, fighting that sometimes in the context of it, like what we do for children and how we set up the rules for children can make a big difference. But what I'll talk about is what happens in the United States. And so the Organ Procurement and Transplantation Network is an agency of the federal government, and they have contracted with a company called the United Network for Organ Sharing, and that's UNOS, to oversee all of organ transplantation. And this was started when organ transplant first started in the 80s, and we needed a set of laws to oversee it. And so this UNOS as an agency oversees all of that for the United States. So they do heart transplant, liver transplant, kidney, intestine, pancreas, and then something called vascular composite grafts, which are like hand transplants or face transplants. So they oversee all of that. And there are committees that are formed within the United Network for Organ Sharing that rely on volunteers. And so the majority of the volunteers that join committees are physicians and surgeons. There are people who run transplant programs. There are parents like Jen Lau, who is part of the Pediatric committee, and they work together under the bylaws. So there's a very, very kind of like hundreds and thousands of pages long bylaws under which you propose allocation policy and changes. So that's kind of that's the big background into what we're working on. When they first started out giving out or trying to determine who is going to be in line to get the next organ or be able to be transplanted, they wanted to make sure that it was given out to reduce the number of people dying, you know, reduce the number of children dying. And the way that they could do that in a fair way is by they started out by using a score called the PELD score. And the PELD score is called the Pediatric End-Stage Liver Disease. And it looks at labs, bilirubin level, INR, which is how your body will clot blood, and albumin level, as well as certain growth parameters that calculate a score. And that is compared to another score called the Model for End-Stage Liver Disease for children above the age of 12 and all adults. And the higher the score, the sicker the person. And so the higher the score, the higher up, you know, on this, you know, what they would say a match list, like the more likely you would be able to be transplanted. How that works when we talk about children who have Alagille syndrome is that children who have Alagille syndrome have other reasons that they need transplants that don't necessarily make that score higher. And so to address that, we apply for additional points, and that those points have to be now reviewed by a national liver review board that then approve or reject an application, and then they get a score, and then they are then, you know, I always say, and this is something that Dr. Rand taught me, is that the list doesn't exist until the patient exists and the organ exists. So there's an organ that becomes available, and then they run a list based on that organ, like blood type, size, all sorts of parameters that are going in, and it gets chugged into a big computer, and the computer spits out what we call a match list. And that match list usually goes by score, and then it is different whether or not you are local, and now right now it's in radius of miles from the donor hospital. But for children, we have set into some policy rules that allow for the organs that come from children that are specifically better for children who are receiving liver transplants to be offered to all children in the country before they would be offered to an adult. And so there's lots of different ways that we've been trying to advocate for kids and make sure that the system is fair and fairly prioritizes children who just operate on in a different context than a lot of the adults who are listed for liver transplant. I didn't want to get too into the weeds about that because this could go on for 3 hours and I could just be still talking at the end of this, but I just want to give kind of an overview of what the scoring system is like, how do we talk about it, and then how do Alagille kids fit into that, because almost always the Alagille kids need extra points and can't just go on a calculated score unless their livers are truly failing, which is really a very, very small proportion of children.
Oh, Roberta, you're on mute.
Thank you.
I just wanted to say the score, the PELD and the MELD scoring is definitely used to help sort of prioritize by degree of illness who should kind of get first dibs for a certain liver. But again, we need to keep in mind that even if we could grow livers in the lab or if we had them growing on trees, not everybody should have a liver transplant, even if they have some liver disease. So there's always a balance between how much risk and how much unpleasantness are you suffering from your liver disease versus how much risk or unpleasantness might you suffer from a transplant. So even if we really had livers for everyone, that doesn't mean that every jaundiced child with Alagille syndrome should have a transplant. And I think that's a really important point. Many of them should if they have complications of liver disease, but maybe not if they don't have complications.
Can any of you speak to living donor versus deceased donor, and if hospitals are different regarding that, and why, and is there a preference?
I can take this one. So living donation, and what living donation is sort of this amazing surgery where somebody who is healthy and able to undergo a very large surgery can donate a small segment of their liver to a child, typically a child. Sometimes you can donate a bigger segment of that liver to an older child or another adult. And that allows, one, for the timing to be really well dialed so that you lower the amount of time that an organ is not receiving active good arterial blood flow, so all of the nutrition and energy that it needs to function well. So if you minimize that amount of time, and also that helps you to really control the timing of the surgery itself and the transplant surgery itself, so you can have a lot better sometimes outcomes because of that. But it's really done in a very, I would say, like a small number of transplant programs across the United States and North America. Part of that has to do with having enough experience and manpower, because it requires surgeons being with the living donor, surgeons being with the recipient, and being able to manage all of that in a time way, and having the ORs and the capacity to do so, as well as the experience to do that. I know that Dr. Kamath's center does the highest volume of living donor transplantation in North America, so she can speak a little bit more about the details of it. But that's kind of why some centers are available to offer it and some centers are not.
Mm. And can someone be on the transplant list at more than one hospital, and also, is there a difference between the allocation of livers at a larger hospital versus a smaller hospital?
That's a great question. Yeah,
and in the support group.
Mm-hmm. That's a great question. I can take this one too, just for the allocation piece of things. So it used to be that depending on where you were, the number of organs that you had available and where those organs would be shared to would differ, because they were given out, first in a region, locally, and then first locally in kind of the donor specific area, which you don't really need to understand, and then to the region, and then it would go to kind of everybody else in the region. So if you're in a highly populated region with lots of transplant centers, it's unlikely to go to another child outside of the region, but those rules have changed now. I think that there's a lot about density of population, the efficiency of the organ procurement organizations, as far as like how well can they get the organs out, and that still figures in as far as like how good of a chance do you have in any different center of getting the organs allocated. It doesn't matter, I don't think, to the size of the center per se, but it might if there's a lot of children listed in your region, and that will come up kind of in that local list before someone else would be.
Okay.
And then with respect to listing at more than one center, that could be a benefit, but it's really the best way to get benefit from that would be to be listed at centers that are widely geographically spread out, which is kind of unrealistic for most people to be going to multiple different hospitals that are 500 miles or more apart. And especially because the center that does the transplant is going to expect you to follow up there for at least a considerable period of time. So it would be quite difficult to get your transplant in California if you live in New York and then expect to have follow-up in California. Most pediatric centers are pretty friendly about trying, taking on the follow-up care of a child that was transplanted elsewhere, but the transplanting center will expect to follow the child at least for the first 6 to 12 months. So there's just a lot of logistical difficulties in listing at a lot of places that are far enough apart to give you an advantage. So I think that's something that people need to take into consideration.
Yeah.
Mm-hmm. Mm-hmm. Thank you.
Roberta, I just wanted to say one thing about live donation, which is of course relevant for Alagille syndrome, which is that since in 40% of cases a parent will be affected, when we're evaluating potential donors for live donor transplantation, we would not, certainly in North America, we would not use a donor that was affected, even if they had had no problems with their liver, if they carried a mutation in Alagille syndrome, if we even clinically suspected that they were the parent that had transmitted the gene to their child, we would not use that person as a donor. Mm-hmm. And that's really just about because your liver may be good enough to live an adult life, but it may not be good enough to be transplanted into your child. And we just want to give your child the best possible chance for the longest chance of success for that graft to work.
Mm-hmm.
Is there a difference? Is there a preference between a live donor and a deceased donor?
Dr. Rand, did you want to get this one, or? I think you speak most eloquently on these.
Oh, well, thank you. In an experience center, really the outcomes from live or deceased donor or a split deceased donor are pretty much the same. So from a deceased donor, you could get a whole liver, obviously, from the same size donor, or a split liver, which is kind of like getting an alive donor, except for you can get more blood vessels from the deceased donor, or you could have a live donor transplant. And again, at an experience center, all of the outcomes should be very similar, but the potential sort of complications are a little bit different. If you have a split liver, either from a deceased donor or from a live donor, you have a cut surface, which can have more bleeding or bile duct leaks. And depending on the relative size of the bile ducts from the donor to the recipient, there can be problems with, they're getting too narrow where the ducts are sewn together. So the outcome variables that we're looking for as children get older may be a little bit different. And then for some children, if they have certain problems in their own blood vessels, like maybe clots, for example, they actually need a much longer piece of blood vessel from the donor. And if you intend for the donor to be alive afterwards, they can't donate the entire portal vein, for example, because they still need it for themselves. So I always think of those vessels, whether it's the arteries or the veins or the bile ducts, it's like a Y. There's a main duct or blood vessel, and then there's a branch, left and right branch that are like the branches of a Y. If you're an alive donor, you can give your left lobe or your right lobe and just that branch of the Y. You can't give the whole stem, or else you got nothing for yourself. So if the donor is deceased, then the child could get the branch and the whole stem, and then another recipient could get the other lobe with just the branch. So there's a lot more, obviously, flexibility with the deceased donor in terms of dividing up the blood vessels. On the other hand, the timing and the health of the donor may be better for a live donor. So there's a variety of differences. If the indication, for example, for transplant is itching and only itching, then the health score is never going to be very high, and it may be a long wait to get a transplant. And in that case, a live donor may be better, or really maybe the only option in a reasonable time frame. Whereas if a person has a higher PELT score, they're much more likely to get a good donor from the deceased waiting list.
That was a good question. Does anyone have any questions so far? Dr. Rand, while you were talking, we could slide right into the next section with your name all over it.
Okay.
Transplant, eval, and other comorbidities such as heart, lungs, kidneys.
Well, really, the main purpose of the transplant evaluation is to ensure that liver transplant can benefit the recipient and that there's not any problems that would prevent the transplant from being successful. And the main purpose there isn't, if you find something that might prevent the transplant from being successful, the purpose is not to be like neener, you can't have a transplant. The purpose is then to address those problems and try to fix them so that the transplant can be done. It's quite rare that a child with Alagille syndrome has some sort of problem that would prevent them from being a recipient. Occasionally, it might be very severe heart disease, which comes into the next part of this. There can be other organ problems, obviously, in Alagille syndrome, which may involve congenital heart disease, ranging from very minor tightness of certain pulmonary arteries to really quite massive complex congenital heart disease. And those things are very important for anesthesia and other issues. Generally speaking, kidney disease is a consideration in Alagille syndrome, even if there's no signs of it in early childhood. That can be something that develops over time. And because the immune suppressive drugs that we use to prevent rejection also have kidney toxicity, in Alagille children in particular, this has to be very closely monitored. And drugs can be adjusted over time to try to protect the kidneys. The other really important part of evaluation is education for both the child and the family to understand what is going to be happening to them, both in terms of the pre-transplant testing, but then also immediately post-operatively and then over the long term in terms of follow-up. And I think nutritional assessment is also such a key part of that. I have seen many children, particularly with Alagille syndrome, who are sent for transplant evaluation where really the problem is nutrition and we can fix it in another way, or itching and we can fix it in another way. And then eventually the children are not so jaundiced and transplant isn't needed. But that said, many kids, if you do need transplant, it's a wonderful, wonderful solution to a problem. And I often tell parents, if your child has a liver disease, you constantly are thinking maybe there's this terrible storm on the horizon that someday my kid's going to need a liver transplant. But I think the way to think about it is try to change your mindset and say to yourself, no, my kid has a liver disease and may or may not develop end-stage liver disease. But if he does, then there's a life-saving, health-restoring alternative, which works really well for most children. And then that way, it doesn't seem like this terrible punishment that that you or your child are getting, but more that it's a safety net that's out there that actually is quite successful. Let's see, what else was I supposed to address? I think that's it. I don't know anything really about the lungs, although I see that's on my list. Evelyn or Binita, something about the lungs?
No, but I was actually just looking on the chat as well. There was a good question from Bryce. I'm sorry, Bryce, I can't see you, but Bryce had a good question about what is the average PEL score that tends to get prioritized on the list. I thought perhaps you or Dr. Rand would, because I think that's a very common question we get in the clinic. How high does my PEL score need to be to get
unfortunately, of course, that does vary, or in the past, it varied a lot by region. And one of the things that the new rules have done is try to set people's scores to be more similar. And the problem is when you calculate them, they're depend on bilirubin, for example. And maybe the bilirubin level isn't that high, but the child has other problems and the score is low. So we, all of us, then write to UNOS and we say, oh, my patient is sicker than is reflected by the score. So can I have 10 extra points or 5 extra points or what have you? And it was pretty unfair because certain regions where we reviewed these things, we gave more points, other regions gave less points, some regions are more populated, like Dr. Hsu mentioned. So now there's been an attempt to sort of normalize that across the country and try to have scores set compared to the median PELD score at the time of transplant. So it's a little bit of a statistical thing, but you can imagine if you sort of average out everyone who was transplanted across the country, and it turned out some kids are being transplanted with the PELD of 2 and others with the PELD of 38, you could get kind of where the median or average is, and you could start assigning that and see how things settle out. But the problem is it doesn't always have to do with the score, because a much smaller baby with a higher score, it's going to take longer than a potentially 6-year-old child, because infants need such small livers, or they need a segment from a very healthy deceased donor, or they need a baby donor, and there just may not be as many of those. So it's not just that you're waiting for an organ, you're waiting for the perfect organ for this particular child. And a lot of times I say to parents, like, look, don't think about this as like a rush to get an organ. If your child is kind of okay, it's not that we want to have a transplant, it's that we want to have a successful transplant that's going to last your child a lifetime. And to do that, we want the best possible donor for your child. And so sometimes we turn down livers that get transplanted into someone else, somebody with cancer or somebody who's dying, where they don't have time to wait for the perfect liver. But I think it's just complicated, this PELD score thing. You can't really compare. It's like when you have children, right? It doesn't really help to compare your kids' grades to their friends' grades, or their PELD scores to your friends' PELD scores.
Can you speak to, if someone had liver cancer, does that take them off the list? Does it pull them up the list? What if it has spread? Because, in Alagille, we do have a percentage of folks who deal with liver cancer, and that is a concern in the support groups.
Well, in general, because liver cancer is often hepatocellular cancer, which is very limited to the liver and often doesn't spread outside of the liver. Liver transplant is actually part of the treatment course. So it's like a debulking procedure. It takes out the majority of the cancer. So the systems are actually set in place to prioritize adults, mostly adults and children who have certain types of liver cancer. Does that answer the question?
Yes.
Okay.
And what are some medical issues that increase the score? Is it increased itching? Is it a liver issue, a further issue? Is it quality of life? Like, what are the things that bump the score up?
So because this system has really changed and shifted in the last 2 years, it used to be you would write an application and it would be dependent on the center who was writing the application, the best case that they could make to a panel of regional review boards, and these were usually people from the region, often who are not treating children, who are looking at these exception narratives and saying, oh, it seems like they should get it, or it seems like they shouldn't get it. And it wasn't really judged on anything that was objective and structured. In the last 2 years, now that we have a national review board that is all staffed by people who care for children. And that's has had its own growing pains as well, because allocation and everything didn't kind of shift alongside with that. Now these applications that you make are reviewed by people who are pediatric, and there is a guidance document that it was put out by UNOS that specifies these are the different things that you should make an argument for, or can make an argument for, and should receive those points. But it's not really consistent even now, although I think it's getting better than it was. But yes, all of those things. So, itching, growth, and development are big things that we think, quality of life is really different in children and can be life-threatening, as opposed to quality of life in an adult or somebody who's having itching.
Mm-hmm. Mm-hmm. Does anyone have any questions?
Roberta, there are some great questions in the chat. I wonder if you want to read them out, because they might be things that lots of people are thinking.
I see one here from Tara Jakes, living donor longevity versus deceased donor longevity, graft survival. Can anyone speak to that?
So all of the big studies that have been looking at it now, there's been a number of things that have looked at this over time. And so, you know, people have gotten better at doing these surgeries over the last 3 decades. So a study that was done perhaps, you know, 2 decades ago is very different from one that was done a decade ago, which is very different from something that's done now. In essence, they used to show the technical variants, long-term survival, and that technical variants are kind of cut down. So anything that takes a whole liver and cuts a piece off of it so that there might be, as Dr. Rand had alluded to, you know, increased risk for bleeding or leaks from one side. Those used to have a worse outcome from deceased donors. And, you know, really in the last few studies done in the last few years, looking at long-term outcomes, they haven't been different at all. Living donors in general do tend to do better, but I think that part of that is selecting for surgical expertise and health of, you know, both the health of the family in general sometimes, and it can lead to a better outcome. And then I think maybe slightly better outcomes long term because of that, the timing and being able to do that. But I don't think that there's anything that's been really definitive on that. I don't know, Binita, would you, from your living donor experience, say that?
No, I think I would agree with that. And we don't make decisions based on that. We make decisions based on the situation and what's the best available at the best in the right window for our patient. Mm-hmm. Of course, if there's ever an opportunity to do a deceased donor rather than a live donor, then we would always take that opportunity because we're then not putting a donor at risk. But we don't believe that there are significant differences in graft survival, just as Dr. Hsu said.
Great question by Jennifer Aponte. What factors are key in matching a patient with a living donor for transplant, and what needs to be compatible between donor and recipient?
I mean, I can speak sort of broadly to that. And I think the most important thing is, well, the first very broad thing is a blood group match, but thereafter, and then size is probably very important. But thereafter, really, the way we do live donor these days, and I'm sure this is the same in America as it is in Canada, we allocate an entire team of adult-focused doctors or adult physicians to evaluate the health of the donor. And this is very important to prevent conflict in the sense that, or bias, because as pediatricians, we hold the interests of the child paramount, and we're not considered objective in the process of evaluating whether a donor is safe to undergo. We could do it medically, but there's always a potential for bias. And so really the health of the donor, the fitness of the donor are really important. And that's why we allocate a whole separate team, including the doctors, hepatologists, surgeons, even psychologists, social workers, to evaluate that donor and the situation. As parents, particularly, or as relatives, we're often approached by people who will say, take a piece of my liver, it doesn't matter what happens to me. And whilst I can completely understand where that comes from an emotional basis, that's not a safe or a practical approach to live donor transplantation. And so I would say the short answer to that question is a blood group match, a size match, and then very important, the evaluation of that donor for their health. And then the only other thing that I would just add to that, and Dr. Rand alluded to this earlier, there are sometimes some technical reasons why a recipient or child cannot receive a live donor. And that's a very particular situation, which needs to be discussed with your team and your surgeon. It depends on the anatomy, but I just want to make sure that it's not just because a live donor is available, it doesn't always mean that it's technically possible. A multi-step process.
So we're to the point, a decision is made, we need the eval. Walk us through what happens to a family. I know we have a few families on that even during the pandemic have gone through eval and transplant, and it's a whirlwind, you know, during the pandemic, but can you kind of walk us through that eval portion and how the family is supported and what happens from there?
I'm sorry, I lost it for a moment. What was that question?
So we've decided that we need an eval, and what happens, like, as far as the eval goes, once that decision is made, what kind of testing is the family supported? Money is always a concern. What happens in that phase?
I'll be happy to take that. The whole transplant process is complicated, and you really do, need a village, if you will, to get it going. Transplant centers always have financial people to help you with your insurance issues. It's in the transplant center's best interest to get paid, so they're eager to help you with that, as you can imagine. The evaluation for the child, as I mentioned before, is partly to determine that they can benefit from transplant and partly to determine that there's nothing to prevent that. And that would involve, making sure they have been seen by a cardiologist. There's, check their anatomy, make sure they have blood vessels open so they can have lines put in for surgery. So there's a lot of sort of standard medical stuff that's done the same really anywhere. In the United States, the CMS, which I forget what that stands for actually, the regulatory body for transplant centers of medicine, requires that certain things be done. So everybody must be seen by a pharmacist to help talk about medications, obviously by a medical and surgical practitioner, but then also by a nutritionist, a psychologist, a social worker, the finance counselor. So you're going to meet with a million people. You're also going to have a bunch of labs, x-rays, ultrasounds, and that can generally all be set up in one horrible long day or spread out over a period of time. And depending where you live with respect to your transplant center will determine how you want to do that, or also how fussy your child and the age of your child. But the process really is, it's a marathon and a sprint. Like people say, oh, it's a marathon, it's not a sprint. But transplant, it's a sprint and a marathon at the same time, because there's a lot of stuff being done at the beginning for listing. And then at the time of transplant, there's a whole lot of stuff being done. And then it's going to gradually get easier. In fact, most parents will say, that by 6 to 12 months after transplant, their kid is on much fewer medications and is much easier to take care of. I often get parents complaining that their children are now hyperactive, but actually their children are now normally active. They were, previously a little sickly and maybe not quite so active. But in terms of preparing yourself and your child, if you've not been coming to the hospital a lot, or even if you have, some children are extremely phobic of staff, extremely phobic of blood draws or x-rays or blood pressure cuffs. That is really going to be a problem. So it would be really best to work with a psychologist to help your child to get used to those things. Because you can't have a fight every single time the kid needs their blood pressure done after their transplant or at clinic. And it's nice to work with a psychologist or child life person, and likely your transplant center can provide people to help with that. Also, you want to prepare yourself and your family for this, perhaps several week-long admission and then multiple follow-up visits. I think it's a great idea to assign, your most irritating family member to be the person that helps distribute. Like if you've got a control freak aunt or parent or something, let that control freak parent, grandparent or uncle or somebody be the person that keeps an email chain out to the rest of the family or something. So you can just have one person that you give updates to, and then that person gives updates to everyone else, so you're not constantly harassed. Mm-hmm. I also often say, of course, right now in the COVID crisis, there's no extra people in the hospital anyway, but depending on a family's preference, we will tell the irritating uncle or aunt, no, we don't allow aunts and uncles at the bedside, even though maybe we do for a different family, but we can be the bad guys. You can ask your team to help you, negotiate with family members who are maybe very well-meaning, but maybe making it worse for you, the parent at the bedside. If it's a live donation by one of the parents, then it's actually a lot harder on the non-donating parent. The donating parent is snowed and, off in the other hospital or something, but the non-donating parent has two people they care about who just had surgery. It's very important to have another family member assigned to the donor. Like if that's your spouse that's over there in the adult wing, that person needs a support person with them that can't be the other parent, because that parent wants to be, needs to be with the kid. So it's nice to work all that stuff out ahead of time as much as you can. Assigning the roles and knowing what is going to happen and what you're going to see post-transplant. Your transplant centers will tell you but make sure you think you have a view in your mind of what this is going to look like. Most people have never seen a person on a ventilator or with lots of drains coming out of their abdomen. So if there's any chance that you're going to see those things, you'd like to be prepared, and know what that's going to be. Sorry, I'm talking really fast.
Oh, that's perfect. That's perfect. And as far as, financial situation, financial help, a lot of our families, they talk about this piece. Does insurance cover, I know insurances are different, but do insurances cover the majority of it? Do families have to fundraise? Does the hospital help them in any way to understand what they need and also help them raise money?
Yeah, the financial counselors can really help with that. For children, it really should be essentially completely covered. There'll still be co-pays for visits and for medications, but the hospitalization and so forth really should be covered either by primary or secondary insurance, at least in the US. There's usually medical assistance available. And like I say, the centers really are well positioned and highly motivated to get those things paid for. There are societies that will help. And there's, for example, for live donor, I'm blanking on the name of it, but probably Binita or Evelyn will remember, a group that will help to raise money to help the live donor who may be out of pocket from taking off work or needs travel expenses covered and so forth. And if the families put some money in, I think that society will match it. Evelyn, do you know that? Do you know what I'm talking about? It's called
the CODA?
Yes, I think that's right.
Yeah.
So, that's a great group. And your transplant center is going to know what's available in your area and what the insurance issues are in your area.
Okay.
Like we're in Philadelphia and we're right next to New Jersey, and the medical assistance situation in Pennsylvania is like 1,000 times better than New Jersey, which is ridiculous. We can have kids who live literally a half a mile apart, and the amount we have to fight with New Jersey is much different from the amount we have to fight with Pennsylvania.
Mm-hmm. We have a question here in the chat. Can anyone speak to the new medicine maralixibat and your thoughts on this? If it could be a game changer for Alagille. We're at the point where we may request added PELD points and push the transplant route due to quality of life, but hearing of this medication has given us pause. Is there hope to delay?
I can probably take this one. So maralixibat, so people who have not heard of it, it's a new medication, and it's in a class of medications. I think just to take a step back so that everybody understands, your liver makes bile acids. We certainly think bile acids are related to itching, but when you have cholestatic liver disease, you get a buildup of bile acids in the liver and in the blood. And in a normal situation, your bile acids go from your liver to your intestine, and then most of them actually get reabsorbed in the intestine back to the liver. So most of your bile acids are circulating from your liver to your intestine, back to your liver, back to your intestine. A small amount gets removed from the body in your stool, but most of it going round and round. And we believe that bile acids are related to how itchy people can get in liver diseases, including Alagille syndrome. What this new medication does, it's taken by mouth, and it blocks the reabsorption of bile acids in the intestine. So it basically breaks that circulation, and it leads to more bile acids being lost in the stool. This is a similar mechanism to what's done with a surgical diversion. And in sometimes people may hear that us using the term that this is a chemical diversion. We're trying to do with a medication what can be done with surgery. So essentially this drug doesn't get absorbed into the bloodstream, it stays in the intestine, and it stops bile acids going back to the liver, and thereby overall reduces or changes the bile acids in the body. And that's fundamentally how it works. I think it's important to understand that. So is this going to be a game changer for Alagille syndrome? I think the first thing for everyone to appreciate is that the studies that have been done, and there's been a big study in North America, which all of our centers, my center, Sick Kids, Dr. Rand's, Dr. Hsu's, were all part of, and other centers in North America. There's been one big study in North America, and there's been one big study done in Europe. And both of these studies were really looking to see if maralixibat helps to improve pruritus. Okay, so at the moment, the main focus with the regulatory agencies, with the FDA in North America and with the EMA in Europe, is about seeing if maralixibat is helpful to reduce the pruritus. So what that means in answer to specifically the question is, we are definitely seeing some emerging and promising data that maralixibat does help with reducing pruritus in some individuals with Alagille syndrome. So I think I could make that, having seen a lot of the data that's published, I think that we can say that confidently. What we don't yet know is whether or not it's going to change the natural history of liver disease in Alagille syndrome. So if the main reason for a liver transplant for Alagille syndrome was pruritus, then yes, sure, maralixibat we know could potentially be of benefit in reducing pruritus. What we don't really know is whether or not it's going to, in a long-term basis, actually change end-stage liver disease or scarring within a liver. So I think that part is still under study, whether we can really change the biology of the disease. I think what we know now is that it's very promising to treat pruritus. At the moment, it's very much, the regulatory agencies are being requested to approve this drug for symptom relief. So there's a difference between treating symptoms and actually treating the underlying biology of the disease. And I think at the moment, what we have the data for today, and this may change, but today what we understand is that maralixibat seems to be very promising for symptom relief.
But let's keep in mind that sometimes symptom relief is all you need because your liver disease is not that advanced and may be great. On the other hand, you know, new drugs are more expensive than old drugs, but there are old drugs that also purport to work the same way, like cholestyramine and Welchol. I forget what the generic of Welchol is. This one has a slightly different mechanism, but unless bile acids are reaching your gut, then there's nothing there for it to help, you know, for it to prevent reabsorption. So if your child does not have a high bile acid level, it may not work. Or if they have a very high bilirubin level and bile's not really reaching the gut, then it's not really gonna be likely to work either.
Mm-hmm. There's a really great question here from Chelsea. Dr. Rand, I see you.
I turfed
on it just a little. She says, hello from the UK. I'm wondering what the opinion on MRI pre-transplant is, specifically neuro. Our liver hospital in London is just starting to push for brain MRIs, and some of the consultants don't necessarily see the benefit. And we here in the support groups, and I personally, with our physicians as well, it's been very controversial. Can we speak to that for sure?
I think we could all speak to it. I will give you my version, which is at one end of the spectrum, and then Dr. Hsu and Dr. Rand can modify it and give you. But I will tell. So you know, it is an area of interest for all of us actually, and we all know how important it is and how much it's a cause for concern amongst families. At our center, and our recommendation is to do a routine MRI, MRA of the head prior to transplant, and we've been doing it for many years. I will say it has nothing that we've ever found on an MRI or an MRA in a patient with Alagille syndrome prior to transplant has either stopped us doing a transplant, nor has it ever required us to do any neurosurgery prior to a transplant. But our feeling is that we know that there's a high prevalence of abnormalities, and we feel that before going into a long surgery with a long anesthetic, with blood pressure changes and shifts, that it would be recommended for our anesthesiologists and the surgeons to have all the information potentially possible. But like I said, nothing we've ever found or that I've ever read about has meant that we couldn't do a transplant because of something we found on a head MRI. So my polarized view is that we should do it. I think the more we do it, the more we will learn. But I can't say that it's actually going to change the evaluation or the outcome of transplant just because we do it. For me, it's information. And prior to a big surgery, it seems to me to be a good time to get as much information as you can.
Are there any questions about that, anyone?
Well, as
I have to say, I share her. I think having learned from both Dr. Rand and Dr. Kamath, at our center we do an MRI prior to transplant as well. Again, saying, you know, there may not be any difference in outcome, although there is somebody that we had cared for many, many decades ago who had undiagnosed moyamoya and then subsequent bleed during the surgery that I think has, you know, shifted the practice here.
Right, so this kind of falls under the category of things that you might evaluate in the pre-transplant evaluation, which don't mean that you can't have a transplant, but might subtly alter the management in the OR or the monitoring afterwards. I'm not a huge fan of the MRI, partly because it seems to me that often it uncovers some tiny little abnormality and then everyone freaks out and it takes a long time to get everybody settled down. On the other hand, I do recognize the potential for finding something that might be important for monitoring. So it's a little bit, to me, of a philosophical question with respect to how are people going to respond to it. And perhaps some of the kids, if they're older children and they themselves are going to have trouble understanding that they have a risk for a problem in their brain, but they don't actually have a problem in their brain right now. For some kids, that's going to be very difficult. And I think probably in my center, some kids do, probably most of them do have had MRIs, but some do not.
Thank you. Any questions? Questions from the gallery?
About age cutoff for head MRI, and the answer is no, because you might have an aneurysm that's been there since you were a fetus and it doesn't give you a problem until you're 50. So there's definitely not an age cutoff for that. There was a question earlier about, heart disease, can that occur later? New structural heart disease cannot occur. Like that is only when you're born with a heart problem or you're not. But these intracranial aneurysms, there may be some very small problem in a blood vessel there that may change over time, or it may just eventually get weak enough that it causes, the vessel wall gets weak enough that there's a bleed. And so that problem could occur later. And that's the argument for doing the MRIs, is so that you know about it, so you can, if you start to feel that your left leg is a little weak, you can rush off and get it taken care of early. And those kind of bleeds, obviously nobody wants to have bleeding in their brain, but there are management strategies and people can do quite well. I had a friend who had cancer and had some left-sided weakness on the weekend. He was a physician, actually, and he decided not to go in because he figured that he had cancer had spread to his brain, and he was like, I don't even want to know. And eventually he went in, and it turned out he'd had a small stroke, and he eventually recovered, but he said, I've never been so happy to have a stroke. So, I didn't think I would ever be happy to have a stroke, but it is a very manageable thing, and I think that's a strong argument for knowing so that you can be prepared and take care of it if something happens.
I have a question. Do you find with Alagille patients, it is likely for said patient to have Perth disease, or is it an uncommon thing?
Oh, I just had a patient turn up with that, and I had not seen that before. Binita, what do you say? Evelyn?
I don't think it's a common association, so it's always hard to know if it's related or coincidence. We know, are we talking about Perth disease? We're talking about the bone, the hip. Is that what we're talking about here, just to be clear?
Yes.
Yes. Okay. Just so that everybody else is. So we're talking about a bony involvement, which I think that we know that skeletal manifestations and bone is involved in Alagille syndrome in terms of the structural part of the bone. We also know that anybody really that has cholestatic liver disease can have what we call metabolic or liver disease related bone disease. So children with Alagille or adults with Alagille syndrome, individuals with Alagille syndrome have two potential reasons why they can have bone issues, both because I think of an intrinsic genetic effect combined with cholestatic liver disease can also contribute to impaired bone health. But I don't think that there's a specific association with Perth disease in my understanding. Dr. Rand, do you think that there's another potential explanation? Is there a vascular explanation?
Yeah, I happen to have a teenage liver recipient with Alagille who just has done fantastic from his liver transplant point of view, but he developed this Perth disease and he had to have this major bone surgery, and it was I was quite surprised. I hadn't seen something to that degree before. So, he's done reasonably well, but it's been quite a hassle. And I just have to admit, I'm not very familiar with the implications, but it's not part of the regular bone disease, right, Anita?
Correct. It's not part of the regular bone disease. Some people in the group will be aware that we've been very fortunate in putting together a big database now of patients with Alagille syndrome with support from the Alliance. We now have a database of over 1,500 patients with Alagille syndrome from around the world, which is really exciting. And this is the kind of thing that we'll be looking at. Yeah, to date, many of the studies that have been done, it's been a few centers or a few hundred patients, but now with 1,500 patients, I think we can really look for associations, and this is the kind of thing that we will look at. So we will go away and look for that right now. But from my initial understanding, it's not something that we've seen a lot of.
Roberta, there are a few questions from the support group page.
Okay.
One of the main ones has to do with biliary diversions. Can one of you speak about that procedure, both partial and total, and when that might be a viable option versus transplant?
I think that's actually in Dr. Superina's slides, and I see that he's come on to the call. I don't know if we want to jump right into that.
Everyone, I'd like to introduce you to Dr. Ricardo Superina. Thank you so much.
Yeah, sorry I'm late.
Oh, you're fine. Do you want to introduce yourself a little bit, and then I can pull up your slides while you're talking?
Sure. I'm the head of transplant surgery at Lurie Children's Hospital in Chicago. We do a lot of all the transplants, all the liver transplants, and all of the non-transplant hepatobiliary work. So I think a lot of people know me already, but I see there's 50 people here, so probably not everybody knows me.
Can you see?
So I put together just a few things for this talk. I wasn't sure exactly how much time we would be having, but sounds like I came in just at the right time when you're talking about these non-transplant procedures that could be done for someone who has manifestations of Allergeals that aren't necessarily worthy of a transplant. So I would just, I'm sure that you guys have probably talked about these already, and I just thought the systemic manifestations of the syndrome, which every time we consider operating on a child with Alagille syndrome, we have to calculate the risk factors, the surgical risk factors of going under general anesthesia, potentially losing blood, and of possibly having complications that wouldn't be even thought about in a patient who doesn't have Alagille syndrome. So chief among those concerns are, does the child have pulmonary hypertension? Does the child have peripheral pulmonary artery stenosis? We would always get an echocardiogram prior to that. We are very conscious about producing hypotension because in the brain there's often vascular malformations that are akin to moyamoya disease that may not have the appropriate tolerance for hypotension. It sounds like you guys are talking about some of the ocular and musculoskeletal problems, which aren't usually a problem in regards to surgery, so we'll gloss over those. And of course, the clinical manifestations of the liver disease, which we're concerned about, which are often consulted in regards to, can we do something for this kid that is short of a transplant? They're almost always related to pruritus. And I don't have to tell parents about how bad this can be. It keeps kids up at night. There was a patient that I just recently operated on whose mother had to get him up every 2 to 3 hours during the night because she would give him milk because milk seemed to soothe him and get him back to sleep again. So we're asked to do procedures, particularly for pruritus. Sometimes the xanthomas are particularly prominent and numerous, and we are asked to do something that might help with that. Now, I must preface my comments by saying that the great majority of what I will be speaking about in terms of biliary diversions are not that well described with Alagille syndrome. They're much more better cataloged in patients with things like Biliary disease or the progressive familial PFEP diseases, intrahepatic cholestasis. I myself have a pretty extensive experience in biliary diversions for PFEP, but I must say that I was trying to look back on my records the last few days. We have really not done a lot of this in patients with Alagille syndrome. So here, can you get the next slide, please? So here, I mean, this is a little boy who actually did have a liver transplant, but we started off with, and you can see he has the typical Allergeal's kind of little face with the, and he had all kinds of scratch marks and xanthomas, and he was itching himself to death. And we did do a diversion on him. Can you, so on the right-hand side, you'll see that there's a number of options. I won't go on to the medications and lotions and baths. I'm sure you already talked about that. But there are 3 essential choices when it comes to surgery. And I don't think that any one of them has been proven to be better than the other. The 3 are an external biliary diversion, which I'll talk about. There's an internal biliary diversion, which I'll talk about, and then there's the internal ileal bypass, which I'll also speak about. Now, I put nasobiliary drainage here because I don't know if the other hepatologists on this call will have done that, but some people, and I worked with Peter Whittington for a long time, and he was one of the first people to describe the external biliary diversion. And a few times, we would try to put a nasobiliary drain in so that we would actually drain the bile through an NG tube essentially. And it was a very difficult thing to keep in place, mind you. So I don't know, it didn't really work out very well most of the times. But the theory behind that was that if you're able to extract the bile from the body before it got into the GI tract and you got an improvement in the symptoms, then that would give you some better idea of whether or not the patient would improve with surgery. Okay, next one, please. So here are, on the left is a cartoon of an external biliary diversion, and on the right is a baby who has had one. So basically the concept is exceptionally simple. You just want to get the bile out of the gallbladder before it gets into the intestine. So what the cartoon on the left shows is a loop of intestine. One end is connected to the green gallbladder, and the other end is basically goes out to the skin. And it's usually a piece of jejunum. You have to be very careful. It shouldn't be that hard, but you do not want to put a piece of ileum in there because otherwise stuff will get absorbed. So we usually use the proximal jejunum. We usually use about 10 to 15 centimeters. So from a nutritional standpoint, it doesn't have any effect on the child at all. And then we put the bowel back together again, and we take this loop of bowel, and it's said that it's a partial diversion because it doesn't really divert 100% of the bile flow. It's said that it basically diverts 50% more or less. But even with that 50% diversion, a lot of children experience a relief from their pruritus. So there was one kid I did who was from Michigan who couldn't play. Remember, he had those, I don't know what it was, a Nintendo or something that he would have to use 2 hands for, and he could only use 1 hand because he was always scratching himself with the other. And to his great, his great happiness, when he went home after the diversion, literally within a week, he said that he could now use both hands to play Nintendo because he didn't have to scratch himself so much. On the right-hand side, you'll see a baby with a stoma. So that's the problem with the external diversions, at least the way we normally do them. You have a stoma, and because the stoma contains bile, and bile is exceptionally irritating to the skin, it has to be pretty much watertight. And a lot of parents have a problem with that. And a lot of people just don't like those diversions because it's got the stoma. And we've had a few children who have grown up who've asked us to do an internal diversion because they just don't like the stoma anymore. You know, it's a social problem, it's a mechanical problem, and they just don't like it. But it works very well. And we used to think it was the gold standard. Okay, next slide, please. Now, the internal ileal diversion is a very elegant solution to a problem that theoretically should work very well. So the theory is that you have the bile salts are reabsorbed in the ileum, so that if you take the ileum out of the circuit, those bile salts will then get dumped into the colon where they will not be reabsorbed. So this is an extremely simple operation. Anybody can do it. It's simply, you just have to be careful, and this is a bit of a guessing game sometimes, is where you think the ileum stops and starts. So I usually take over 100 centimeters of bowel, measuring back from the ileocecal valve, which is where the ileum meets the colon. It's where the appendix usually lies. And you measure 100 centimeters, that's about 3 feet of bowel. And then after you've measured that 3 feet, 4 feet sometimes, just to be on the safe side, you divide that bowel. And then the proximal end, which is the jejunal end, is plugged into the side of the cecum. And you can see it there. It's like the upper loop of bowel that is plugged into the ascending colon. And the ileum that has been excluded just kind of lies there. And we don't do anything to it. We just, it's just not able to participate in the, well, you know, that's the wrong word. I mean, it's just not exposed to the bowel content. So the bile salts are just go by it. They don't get reabsorbed and they go into the colon. And sometimes the stools become a little looser for a while. I think it's probably because bile salts shouldn't be in the colon to begin with, and so they have an irritating effect on the colonic mucosa. But most of the time, children get over it, and I don't hear too many complaints about diarrhea. The ones who've had a stoma experience great joy at not having stoma anymore. And we've studied this problem. We were worried that the kids who had stomas who were doing really well would actually kind of reverse their good course and worsen, but that has not happened. We actually wrote up our experience in the Journal of Pediatric Surgery a few years ago, giving this insight that we had that converting the partial diversion, external diversions to the ileal bypass did not cause any regression. So that's basically all I have to say on the external biliary diversions. This thing here was just a cautionary note that children with Alagille syndrome can develop cholangiocarcinoma long-term. There have been numerous reports of children with cholangiocarcinoma. I don't think it's as common as it is with some of the PFEP diseases, but it's certainly something that we have seen. And on the top right corner is a liver with cancer in it. And on the bottom is another liver where cancer was found at the time of the transplant in a sort of an occult fashion. It was called carcinoma in situ. But these children are subject to that problem. Next slide, please. I think that's all I have right now on the diversion. If anybody has any questions, I'd be happy to answer them.
Great. We were having much more back and forth discussion, I think, before you came in, Rick. So maybe we should go back to that format. Let's see if there's new questions.
I've got a
related to what Rick just.
Can you hear me?
Yes.
Oh, hi. I'm just wondering, why would you do an external diversion if you could do an internal one, given that patients would much rather have an internal one without the stoma? Like, what are the decisions that have to be made? And I've heard that they happen during the surgery. So what happens for a patient to need an external diversion rather than an internal one?
Maybe I can start with that, and then Rick can climb in too. The external diversion was invented first, so that was initially the only idea. And as Rick said, Dr. Whittington actually invented it. He had the idea he wanted to study bile the components of bile in children with Alagille and other disorders. So he did put down an NG tube, but he put it all the way down so it was close to the bile duct. And then that way it would drain some of the bile out, not all of it. And the kids could still eat during the day, but at night he drained the bile. And astonishingly, many children that were extremely itchy stopped itching on the third or fourth day of this process. And the process was not meant to treat the itching, it was meant to collect bile. So following that, Dr. Whittington and his brother, who was a surgeon, tried some different attempts of how to hook up a way to do this more permanently, including trying to put a tube into the gallbladder and various other things that had logistical problems. And they eventually came up with the external diversion, which actually works the best. And I know Dr. Superina says the internal one works as well, but it doesn't always. A lot of kids do have a lot of diarrhea, and the diarrhea will get worse over time because the end part of the bowel will sort of adapt so that it can reabsorb, because it thinks it's supposed to be reabsorbing. So I have seen children who have converted back from the internal to the external because of a combination of diarrhea and or worsening of itching as the bowel intestinal capacity changed. So at my center, we tend to offer the external. We think it works better, and we don't have to go back and forth. But it is a lot of people don't like the stoma. There are some other options that can be done with that stoma in terms of keeping a closed loop of bowel under the skin and trying to put a G tube in there, like a low profile G tube that could be closed, for example, if you went to the beach, but opened at night for draining. So there are some other tweaks that could be done, but I think there's just different experience at different places. I've not heard of making the decision in the OR. Rick, has that ever been your system?
No, we are, like you said, I think the external diversion was thought about first, and it seemed to be the simplest thing. Although I still don't understand why it works, because I think, but anyways, that's a whole other topic. But the decision is made ahead of time. There are some patients who are very well informed and well read, and sounds like the Allergeal families are like that, but so are the PFEP families, and they will come to you and they'll say, we do not want a stoma. We want to have the internal diversion. And if they say that, then we'll just go ahead and do the internal diversion. And there's not been any really randomized prospective studies that actually look whether the external diversion is better than the internal one. It's just a feeling that I think the people who, like you said, Peter was someone who was a strong believer that the external diversion worked better. But honestly, when we have reversed them because patients just don't like having a stoma and converted them to an internal ileal bypass, we have not seen symptoms getting worse. So that's been our experience here.
Is there
that data? Because I think that around the country there are people who've had conversions to the internal and then gone back to a conversion to the external. But it's all sort of different people having just a few experiences. So unfortunately, we don't have a large amount of data.
Yeah, I must say that I have not really done as much of this with Allergeals as I have with PFEP. So most of the experience that I'm talking about is in PFEP patients.
Yes, I think I was just going to hop in. I think that's what Dr. Superina and Dr. Ann is saying is crucial. And in the Children Network, which is again this big research group, one of the surgeons from Los Angeles, Dr. Casper Wang, has published a paper on the experience of diversions. And we were all interested that when we've all got limited experience, and when we pulled our numbers, looking at the number of diversions in Alagille syndrome, far fewer are happening on our continent than perhaps we realize. There really is a very limited number of diversions happening for Alagille syndrome as compared to PFIC. So I really do think that I think it's very hard to know exactly what the right thing is to do. I don't think that we really know. In our center, just to add to the experience, similar to what Dr. Rand says, my impression is that, as has been said, diversion does not work as often as well for Alagille syndrome as it does for PFIC. And because I have just had the experience that I think that external sometimes work better than internal, I say to my families, if we're going to get the best shot, let's go for the best shot, which is try external. That's it. But again, these are anecdotes and limited experiences. But even when we pooled this data across 14 centers, we still don't have definitive answers.
Mm-hmm. So that kind of leads me back to transplant. If a family is faced with, do we do a diversion versus let's push, towards transplant, what is the better choice? Could the diversion fail? And then they're like, well, we should have done transplant.
No. Look, a liver transplant is a lifetime potentially commitment to immune suppression and multiple other issues. You should, if the liver is otherwise healthy and there's not cirrhosis or other functional problems, then a diversion should be tried. I've seen lots of families, more with PFEP than with Alagille, who want to just have a transplant because they can't be bothered to have a stoma. And I'm sorry, but like having a liver transplant and being on medications that can cause significant side effects over years or decades, like that, you shouldn't be making that decision for your 3-year-old because you don't think you want to deal with stoma. Like, you just have to, kind of take a deep breath and deal with it. It's not worth the risk and the potential injury. I've never heard of somebody dying of a complication of a biliary diversion, but people do die from complications of transplant.
Mm-hmm.
Liz, I just want to jump in though. We have had patients who have had such severe electrolyte disorders from fluid losses from their stoma that we've actually had to reverse the stoma. And that was a couple of patients actually got transplanted because they just got so sick with their diversions.
Right, not sick with liver disease though, but that would be where afterwards, you give them IV fluids and you can't, figure out the electrolytes and then you do the transplant. But doing the diversion first in a patient who does not have advanced liver disease is the right thing to do. I mean, I don't think you could argue that taking a child without serious liver disease directly to transplant, if you have another option,
Mm-hmm.
is the right thing to do. I think that would be wrong.
Right. And actually, Roberta, this actually links a little bit to a question that was in the chat earlier that we didn't talk about, where there was a question about if we know that many kids are going to need a liver transplant, or if we know that why not do it earlier, right?
Right.
What Dr. Rand is talking about is about, even though we're here to talk about transplant and talk about how it's life-saving, and it is really it's not an experimental therapy, we know it's highly successful, it is still a huge step. And so we don't do it unless we really believe it's necessary, and B, we don't do them prophylactically. What I mean is we don't do them earlier than they're necessary just because we think they might be needed later. Because there was a question about that, about some of the work that we've done about trying to predict liver disease outcomes.
Mm-hmm.
And so I think it's a very legitimate question. I get asked this a lot in clinic, and families say to me, my child is already jaundiced, from a probability standpoint, if we know a transplant's going to be needed later, why not just do it earlier? And this just, again, speaks to balancing risk and benefit. And people really have to appreciate that transplant is a big step and it's a lifelong commitment. So we really want to be sure that a patient needs it. We don't want a patient to get too sick. We don't want them to get too sick before we do it, but there is an optimal window. You do still need to be sick enough to need it. So we don't do them in anticipation of somebody getting sick.
I think there is a misconception of that. I mean, as parents, I could probably say at least half of us in this room have heard, well, can't you just get a transplant and it's better? And I know that you guys probably combat that even in the clinic setting as well. There is a feeling like, okay, well, transplant will be better, but it's really, you're trading one set of problems for another. And we really need to understand the depth of that,
Yeah, and it's a kind of a personal question, right? And a personal answer as to when do those, we have, as your medical team, we know when those lines cross,
Mm-hmm.
where on one side, whether the risk and the benefit weighs on one side more in favor of transplant or not in favor of transplant. But some of those, because it's the quality of life, developmental issues, like we have to be able to have this conversation, and that box moves a little bit based on how much, how able are we to modulate the risks of transplantation, which I think is also changing has changed in the last 30 years, will continue to change in the next 30.
Mm-hmm. Mm-hmm. So do we want to roll into your next slide, Dr. Superina, the liver transplantation risk factors?
if people want that, sure.
You know, I think, you know, we hear in the Allergeal community very often that liver transplants for Allergeal families are much different than liver transplants in other disease states. Can you speak to that a little bit? Are there risk factors for Allergeal patients versus other patients with cholestatic liver disease? And if so, what are they?
Okay, so yes, Alagille syndrome, I never take anything for granted with an Alagille's coming up for a transplant. I have a very healthy respect for the kinds of things that can go wrong, and they can go wrong quickly. I would have to say the first thing, I sort of prefaced my remarks about the operative risks for Alagille's when I was talking about the diversions, but we have had patients who have had such severe pulmonary hypertension that we cannot transplant them. So that's a huge thing for us to make sure that their cardiac function is good enough to withstand the transplant. Some people might argue that if the hypertension is half or 2/3 of systemic levels, that the patient is not able to get a transplant. And we have turned down Alagille's patients for transplantation for exactly that reason. You know, one of the old terms, I don't know if anybody remembers this, I'm sure some people do, that Alagille syndrome had a kind of a nickname, it was like a hepatic arterial dysplasia. And I think that speaks to the fact that there's something abnormal about the vascular, the vessels in patients with Alagille syndrome. They can have, I put examples on that slide where anybody with Alagille syndrome has to have a very careful evaluation of their arteries and because they can be very, very abnormal. So on the top slide, you can see it's kind of a sagittal view of an old CT scan where you see two vessels coming off the aorta. The top one is the celiac axis that has a very, very severe stenosis. So that could not be used for a liver transplant. And on the bottom, you have a CT scan of a child with extensive abnormalities in their hepatic arterial supply, as well as some of the other arteries in the abdomen. So when we come to transplant a kid with Alagille's, we have to have a very good understanding of what the arterial supply looks like. And I actually do not, you know, it'd be interesting to see what other people have to say. In general, do not want to do living donor transplants in patients with Alagille syndrome because I want to have options, vascular options, that if something goes wrong, we're not limited to what a living donor can give us. I like to have vascular grafts. I will often transplant the hepatic artery of the donor vessel directly to the aorta because I just don't trust that the hepatic artery of the donor of the recipient, I'm sorry, will hold the sutures well enough. What's the next slide there? I forgot oh no, never mind, go back. So we have actually only transplanted 11 children with Alagille syndrome out of about 450, 500 transplants. So it's really a very small percentage of our total volume. I think most patients with Alagille's thankfully can be managed without a transplant, but I'm telling you that those 11 cases were all pretty challenging. And I think we haven't written about this, and I'm sure somebody has. I think there's a greater number of vascular complications after the transplant in kids with Alagille's. I remember one of the last kids we did was a little baby. He was maybe a year and a half old, and had a very rocky transplant. And we sort of did a delayed biliary anastomosis. When we went back a few days later to do the bile duct, we found that the artery had thrombosed. We didn't even suspect that. So thankfully, we were able to salvage that at the time. But patients do have a higher incidence of vascular complications, I find.
We hear sometimes that the vessels with Allergeal patients are very much like fishnet stockings, like they just are very weak and it's hard to work with them during transplant. Can you speak to that? Is that true?
Well, that's why, no, you're absolutely right. That's
Rumor
why
mill. We have a rumor mill. We have to
we don't, like I said, I don't like doing living donors because we would have to use the hepatic artery. I want to use an artery that's the most substantial, and that's the aorta. So we would put a vascular graft down to the aorta, which is, I think, the strongest artery that there is in the body. And that usually works quite well. And then we would hook the donor hepatic artery to that graft.
Mm-hmm.
Actually, I think what, Roberta, I think what Dr. Superina is speaking to is exactly spot on to the national experience. So there have been 2 large studies that look at liver transplant outcomes in Alagille syndrome. One was from the UNOS database, and one is from the SPLIT group. And since this is a SPLIT-sponsored webinar, I think it's very nice to look at the SPLIT data. And in that SPLIT study, we looked at the outcomes of 100 children with Alagille syndrome, and we compared them to almost 300 kids who had liver transplants from biliary atresia, which, as we all know, is the most common cause for liver transplantation. So it's a nice comparison group, right? So once you select out the children with bad cardiac defects, just as Dr. Superina said, we all know for sure that there are kids with bad cardiac involvement that are not good candidates for transplant. But once you remove that group and take what I would say is a group of Alagille syndrome without a significant cardiac defect, and you compare the outcomes of kids with Alagille syndrome and biliary atresia, they're not that far off.
Mm-hmm.
They are slightly reduced, but they're not that far off. So what I think that teaches us is that if you carefully select patients for Alagille syndrome for liver transplant, they can do extremely well. Looking at that group, back to Dr. Superina's point, it is true, absolutely, that when we looked at the use of, I think a broad way to say it is the use of surgical grafts, right? So speaking to the vascular problems, in 3 times the number of cases with Alagille syndrome as compared to biliary atresia, surgeons across North America were 3 times more likely to use some type of arterial graft in Alagille syndrome as compared to BA. So that is exactly right. It is exactly right. However, with the talent of the transplant surgeons that we have and the techniques that they have to do arterial grafts and jump grafts and different mechanisms, we can still achieve excellent outcomes. And I think that would be, so I would say, yes, it's a more complex situation to go into a transplant for Alagille syndrome. Yes, there are surgical difficulties. Yes, there's more evaluation in the cardiac side. Yes, you may have to consider a head MRA. But the big picture is we know from the outcomes that kids can do very well after liver transplantation with Alagille syndrome. So I think that even though the team has to be aware of the complexity, with the right thinking and surgeons who are very thoughtful and talented and the right evaluation, we can achieve excellent outcomes.
Thank you.
Would you agree what I said about living donors?
Well, Dr. Superina, I absolutely appreciate what you say. Unfortunately, in Canada, we don't have that option because we have such limited availability of deceased donor grafts. So more than 60% of our lists, so we do approximately 30 transplants a year, 60% are live donor. So we do a lot of live donor for Alagille syndrome. With careful, we, as I had mentioned earlier, I think perhaps before you came on, we don't use anyone that's a JAG1 mutation carrier or not anyone that has a mutation, but we do have to do it, but absolutely appreciating, and our surgeons say exactly the same thing that you say, which is that it is more challenging and that the vessels are harder to deal with. But unfortunately, we don't have a choice, and so we do end up doing many live donor. We're probably doing 3 to 5 transplants a year for Alagille syndrome, and the majority end up being live donor. So it's really more a question of we don't have the choice.
Mm-hmm, mm-hmm. So we had a question in the chat here a little bit ago. I think Dr. Rand, you touched on it. When a child has a Kasai, does that interfere at all with a transplant? Can you speak to that a little bit for the group?
Sure. There's actually another question that just came through about the possibility of having both biliary and Alagille, which sort of feeds in. Children with biliary atresia have obstructed bile ducts. And so they have this Kasai procedure in an attempt to reestablish bile flow. Children with Alagille syndrome have abnormal bile ducts. And in some cases, maybe just that disease is much more advanced. so that it appears to be completely obstructed in infancy, and Kasai procedure may be done. Is that wrong? Maybe. Binita and I actually did a paper some years ago showing that if you do a Kasai procedure in a child who turns out actually to have Alagille, that the outcomes are worse than they are in biliary atresia. But really, that may just be particularly severe Alagille syndrome of the ducts. I mean, the heart disease ranges in severity, so maybe the duct disease does as well. But that said, once you've had a Kasai procedure and you come to the OR for the transplant, from the surgeon's point of view, it's all the same. I mean, you're going to take out the liver, you have to pick it off of that roux limb that's used to connect it, and then you're going to implant the new liver into that intestinal connection. And many children with Alagille syndrome, if they have never had a Kasai, which is most of them, many of them, their own native bile duct is going to be too small to sew the donor bile duct and the recipient bile duct directly together. So the surgeon will have to use a piece of intestine for that connection anyway. So it's either a matter of they get a new roux limb at the time of their transplant, or they're using the old one that was done at the time of the Kasai. But because biliary atresia is the most common indication for transplant, all pediatric liver transplant surgeons are very used to coping with that previous surgery and picking through the adhesions. I'm sure Rick can say further, but I don't see that as a problem from the transplant point of view.
I agree. I think that clearly no one wants to do a Kasai procedure in someone with Alagille. I think it's
right.
A mistake.
Yeah, it probably is a mistake, but it can happen with best intentions, because it can be very difficult to distinguish in a young infant. I think that happens much less now than it did 20 years ago. Yeah. I do think it can happen. And I have seen some kids with Kasai procedures for Alagille syndrome who did well for a period of time. So I don't want to throw stones at someone that did a Kasai, but I think if it would be much better not to do it in most cases.
So could we move on to post-transplant and itching, pruritus, unique Alagille complications post-transplant, and then any medications, vaccine requirements, immunosuppression, all of the post-transplant stuff. And then we'll move into
the vaccines. And then there were some questions in the chat that I answered a few of about itching after transplant. And itching after transplant has nothing to do with Alagille anymore. So itching is a common cause of cholestasis and high bile acid levels, as we've heard, which can occur after transplant for different reasons. Children can get viral infections in their liver, they can have rejection, they may have strictures, that narrowing where the bile ducts are sewn either to the bowel or to each other. So if you have itching after transplant, it still has to do with your bile ducts. It does not have to do with your Alagille. And some of the management strategies are similar, but the most important thing is figuring out, why did the itching come back? If it's rejection, you really need to treat the rejection. In the meantime, some ursodiol or some naltrexone may help with your symptoms, but you really need to find out why, because a person after transplant should not be itchy. And then vaccines, I'll say a couple things about vaccines. Everyone should get them. You should get all of them you can. I always get every vaccine I'm possibly eligible for. And for children who are going to be on immune suppression, it's ideal to get as many vaccines as possible before transplant. And I require children to have transplants and to have immunizations in my program appropriate for age. So if you're coming to have a transplant, you can't say like, yeah, but I don't really like the idea of immunizations. That's just not right. Like if you're having such a high impact, high maintenance thing done as a transplant, then you should be in for the low impact, normal preventive care of childhood, which includes immunizations. The one area of controversy is live virus immunizations. As much as possible, you'd like to give those before transplant, because then you don't have to deal with the issues of having a live virus given to you when you're on immune suppression. But I published a number of papers, and so have other people, regarding the use of live virus immunizations after transplant, once the person is weaned off some of their medicine, so they're just taking a single drug like either cyclosporin or tacrolimus, and that's been shown to be effective and safe, and I don't see any reason not to protect our children and our transplant recipients from measles and chickenpox. And I hope that everybody would get all the immunizations they can at every age.
We do have one question here from an Andrea. For a child that's almost 4 years post-transplant, what could be the cause of pale, loose stools? And all labs have been stable.
Well, if by stable we mean normal, if the bilirubin is normal, then whatever is causing the pale stools is probably not important. Sometimes you just have to leave the stools alone. You know what I mean? Like if the person's not losing weight and they don't have an elevated bilirubin, you know, maybe they're eating clay behind your back. You know,
all Alagille families are used to inspecting it, so
yeah.
we're.
Story I always tell my stepfather-in-law once called me from Florida to ask me, what does it mean that he sees like those cells that form a section of grapefruit? He sees those in his stool. He said, does it mean anything? And I said, yes, it does mean something. He's like, what? What does it mean? And I said, your face is too close to your stool. And so sometimes we're just looking too closely. You know, we got to know when to let it go.
We have a question about COVID and transplant. What are your thoughts on any increased transplant issues with the current COVID landscape? And we do have a couple families in here who have had a transplant during this time, and it's whirlwind.
I can say that there is a group through Split and NASPGHAN that's collecting information on children who have had transplants and have also been infected with COVID-19. Overall, there are not, we haven't been seeing increased risk of disease or increased complications in children who seem to be not as affected by COVID-19 as adults are and older individuals are. There may be even some, I think there is definitely some protective factors in that these are families who have been used to being, isolated from other families after transplant, have been guided to do so. And so I have been well versed in kind of quarantining and hand hygiene and staying safe. So there's probably some protective there. There's been theories that have thought that because the severe reaction to COVID and severe manifestation of COVID has to do with immune system reacting against itself to cause really bad outcomes, that in fact children who or individuals who are on immunosuppression may have some sort of protection from that, but that has not completely played out yet.
Can you speak to why some children need 2 and sometimes 3 transplants versus 1, and what are the complications that might cause that? Anyone?
Well, I mean, there could be medical or surgical reasons. Sometimes children have multiple transplants, one right after another, because the first liver has primary non-function, and so emergently retransplanted, and then that has hepatic artery thrombosis, so emergently retransplanted again. So if you have a couple of transplants right close together like that, usually the outcome pertains to the last liver that you got, and it is often very good. Some people have complications with their liver much later. Could be chronic rejection. Sometimes teenagers don't want to take their meds, and they just get chronic rejection. And then even when they get back on the straight and narrow, you can't salvage that graft and you need retransplant. Sometimes there can be vascular compromise to the graft late, but I think most of the late retransplants are due to chronic rejection. And many of those, not all, but many are related to failing to take medication, which is a very sad thing, but I think is true.
Here's a question about COVID again. When the COVID vaccine comes out, can transplant kids receive the vaccine, and after how much do they have to wait to receive it?
Well, we have to know what the vaccine is before we can answer any of those questions. I will say about COVID, there have been a few case reports published of children who contracted COVID, and to me, one of the most interesting ones was a live donor transplant. I think this was from Italy, where the child clearly contracted COVID from the transplant, or they were able to genotype or serotype or something. The donor and the recipient had the same COVID. So that was fascinating, and the child recovered fairly uneventfully, it seemed, but I thought that was a fascinating story because the child was getting infected at the very moment of getting the most immune suppression, and yet recovered without any, didn't require prolonged ventilation from a ventilator or oxygen, really did quite well. We've had a couple of kids who turned up positive because they got tested really for irrelevant reasons and have not been sick at all. So, but we also know that even in the general population of, general healthy children, most do fine, but some are very severely ill. So I think obviously we can't predict the outcome even in healthy children, so there's no way we can predict it in children on immune suppression.
Any recommendations on whether children who have been transplanted should go back to school?
Actually, I will try to find and post onto the chat a link because the combined immune infectious disease group that does transplant to put together a statement about what you should try to achieve for school, and it's endorsed by Split and by the Kidney and other societies. So I'll find that link and I'll post it on here.
And I'll share that. Okay. We have another question here. We were told that, this is from Lana, we were told that ALGS kids after transplant may still have issues gaining weight. Is that your experience as well?
Binita, do you want to take that one?
Sure, I can take that one. I think that, we know that growth impairment can occur pre-transplant with Alagille syndrome for multiple reasons. We know that growth and stature, height may have a genetic contribution, and on top of that, you have cholestatic liver disease that impairs growth for the reasons we've discussed. So post-transplant, we expect that kids with Alagille syndrome, that their weight gain would improve. Whether or not it's going to be perfect or not is obviously up for discussion. I think what we've seen from the research, again from the study where we compared growth after transplant in Alagille syndrome versus biliary atresia, kids with biliary atresia come to transplant bigger, and post-transplant they're bigger. And I'm talking about height and weight. So yes, that's a given. And it is a given that kids with Alagille syndrome are often small. However, what's really important is that post-transplant, kids with Alagille syndrome experience more catch-up growth than kids with biliary atresia. So I think that's really important, because I really worry sometimes that there is a tendency for people to believe, oh, kids with Alagille syndrome are small, so that's okay. That's not okay. There's a lot that we can do both pre-transplant and as a benefit from transplant, and we can see significant catch-up growth post-transplant. So if your child may have issues gaining weight depending on how the transplant's going, depending on whether they have oral issues with feeding. We know there are lots of those issues that happen, but I think the capacity to get benefit from liver transplant in terms of weight gain absolutely exists in Alagille syndrome, and we do expect improved growth. You're not going to make your child huge, but you could certainly optimize their genetic potential for growth by transplant.
And I think it's something else that might be interesting. I'm sorry, Roberta. I think, for biliary atresia, really sick biliary atresia patients, we've put them on TPN and gotten them bigger and made them healthier at time of transplant. And I guess the question, even that I would have for my colleagues here is that, we've also seen some benefit in Allergeal patients that we put on TPN with severe liver disease prior to transplant with better outcomes post-transplantation. Whether or not we should be moving in that direction as far as, bridging them there or getting them to a better situation.
And yesterday, Binita, briefly, we were talking about puberty, transplant before or after, and is there a push either way? Will a patient catch up post or just pre, or does it matter on their age or their hormones or their puberty? What happens there?
Sure. So first of all, just addressing what Dr. Hsu said, I think that we should treat Alagille syndrome children the same as we treat biliary atresia children, which is that we should offer them every advantage to help them grow, whatever is appropriate in your center, appropriate for that child. I really just don't like the approach that Alagille syndrome children are small and therefore we shrug our shoulders. We should do the best that we can. So yes, if at your site you're being offered TPN and you're being told that that's what they think that they can further optimize growth, then I think that is a great option if that's what works there. And to your question, Roberta, I think that's a question really about if we're doing a transplant post puberty. So if a child has reached their final height, we're not likely going to increase growth after that. Once your growth plates are fused, if you do a transplant post-puberty, I don't think we're going to achieve any more height. You can certainly achieve optimized nutrition, which is of course very important, but I don't think that we can actually increase height after in a transplant post-puberty.
Okay. This one is a question about Notch 2 version of Alagille. My son has Notch 2 version of Alagille. Could that change the eligibility or type of procedures that he would be eligible for?
Not as far as we know at the moment. There's still only a handful of individuals with Notch2 related Alagille syndrome that have been reported. We've got some new information on that will be coming out. And as far as we can tell, if you have liver disease related to Alagille syndrome from a jagged 1 mutation or a Notch2 mutation, they seem fairly similar. What I don't know yet is whether you're less likely to have liver disease if you have a Notch2 mutation. But once you have liver disease associated with a Notch2 mutation, as far as we can tell, it behaves similarly. And therefore, in our approach from a transplant standpoint, I don't think that we would treat a patient with Notch2 related liver disease differently.
Okay. How long-term, can you just talk about the long-term use of immunosuppressants that affect Alagille patients?
Knock it out, and then it can be. Well, it's at the very peak of the root.
So I think the one thing that makes Alagille patients a little bit different is the fact that some of them can have kidney issues, and that the main immunosuppressant that we want our patients to be on long term, and the best one that we've been using, is a medicine called tacrolimus, which is processed through the kidney and can cause additional kidney stress. Sometimes there are different ways to approach immunosuppression to be a little bit more kidney sparing, to aim for lower tacrolimus levels with an adjuvant type of immunosuppression like MMF or mycophenolate or azathioprine. I don't know, Dr. Rand, Dr. Kamath, if you have any other thoughts about that.
Totally.
Everyone has risk of long-term complications from immune suppression, but they're pretty much the same, except for, I think, kidney is an area of focus. And we monitor all liver recipients for kidney injury. And, you know, when I entered this field in 1990, a higher percentage of children who had liver transplants ended up needing kidney transplants. It was fairly considerable because we just didn't know we were trying to use immune suppression, and they had a lot of kidney injury. And now we are very attentive to limiting other medications that can cause kidney injury, such as antibiotics like gentamicin, or fever medications like ibuprofen. We really try to avoid those things, but we can't avoid the tacrolimus and cyclosporin because those are the cornerstones of immune suppression. But sometimes we can use a lower dose and add in something extra, like was mentioned, and that's something that all of us liver transplant people are used to paying close attention to.
Yeah, I just add one more thing, which is that there are a couple of papers out there that describe an increased frequency of immune system issues. This is pre-transplant Alagille syndrome. There have been a couple of papers from the UK that have come about that. There's some interesting scientific data about it, but I have to say, from a clinical standpoint, when we're taking care of patients with Alagille syndrome, pre-transplant and post-transplant, I do not think we see an increased risk of clinically important infection. So yes, there is a theoretical basis that could the Notch signaling pathway, could jagged one be involved in your immune system? Maybe. But as day-to-day taking care of these patients, I'm sure Dr. Hsu and Dr. Rand would agree with me, we do not see an increased risk of serious infections pre or post-transplant. And therefore, Alagille syndrome patients need to take their immune suppressants the same as any other post-liver transplant patient.
And can you speak to Alagille patients that need more than just a liver transplant, multiples? What have you seen? How often does it happen? Have there been any three-way transplants with like lung, kidney, and liver? Is it rare? Do you see a lot of kidney and liver together? Kind of speak to that a little bit.
From the literature, we've done no combined. We do combined liver kidney regularly. I'm sure my colleagues, Dr. Ryan and Dr. Hsu, do as well. Liver kidney is probably the one that's most often combined. For Alagille syndrome in the literature, what I've seen are a few isolated reports of liver heart. You can of course, as we've talked about, imagine why that would be necessary. I have to say we've not done it at our center. We have in general tried to correct cardiac defects before we send a patient for liver transplant, if that's feasible. But I'm happy to hear if Dr. Hsu or Dr. Rand have experience of liver cardiac. I think it's a very rare event.
Dr. Rand shaking her head no over there. You're
Oh,
muted.
she's on mute.
You're muted.
Yeah, that's really hard for me to be muted. We've done one liver heart transplant here, but it wasn't in an Alagille syndrome child. So same answer, really.
And we have one patient who was done, you know, almost 2 decades ago now, who is undergoing a workup for kidney transplant. So we've never done them, you know, contiguous, but I think that is, as Dr. Rand had alluded to, a lot of the patients who were done 20, 30 years ago, regardless of Allergeal or not, are seeing some kidney transplants now.
Mm-hmm. So we see a lot in the support groups and with families, the heavy cardiac and the severe liver. And we have seen the tragedy of some of the children passing away, that their heart was so significant that they couldn't undergo a transplant. And when they do pass away, you can imagine the entire Allergeal community is affected by that. There is an underlying fear for those who have cardiac. Will their child ever be able to have a liver transplant? And I know, Dr. Rand, you touched on this a little bit. Can we go just, I know we have only a few minutes here, but can we take a little bit of a deep dive on this and ensure, you know, families that maybe this isn't as common as they might think, or maybe it is? And I also see Dr. Ebels here, you know, maybe she could hop in on this as well from Stanford, but our families are scared when they have both of these. And
Sure. Yeah. The children that I've seen who could not undergo liver transplant due to the complexity and severity of the heart disease were infants, and sadly died in infancy. I don't think I've ever been confronted with a child who was, you know, a child age, a toddler or older, that was a completely limiting factor. It may have been an issue, but it wasn't something that prevented transplant from going forward. Although I can imagine that might be a case. I think it's a rare event outside of infancy. What do you guys think?
100% agree with Dr. Rand. This is generally an issue of infancy. I think I've yet to see an older child who couldn't proceed with transplant without some cardiac intervention before, and we've been able to get a child transplant. And actually, that's what the research shows as well, is that it's one of the most important factors for mortality in the first 6 months of life is the severity of your cardiac defect. So it's not that, and it's a tragic situation when you have a very young baby in the first 6 months of life who passes because of a cardiac defect. But it's not so much that you couldn't get the liver transplants, it's more that the severity of the cardiac defect was so immense that they couldn't do the appropriate cardiac surgery that was necessary. But I think beyond that, once you're in the school age child, just as Dr. Rand says, now our cardiologists are very talented. They can do a lot of non-open heart surgery, and we can get those kids to liver transplant.
Okay, we have one more question from Chelsea. She says, I'm curious about vitamin supplements pre-transplant. Our son has been on monthly vitamin D injections, about to start vitamin E injections, and had IV vitamin K today. These are all given clearly at much higher concentrations than the average child. Should there be any other vitamins given at higher concentrations? Also curious about probiotics pre and post-transplant.
We could see those up. I don't like probiotics ever for under any circumstance, and certainly not post-transplant. I mean, they're expensive dead bacteria, and you can get cheap, nice tasting bacteria in your yogurt. So there's really no reason to take probiotics in my view. There are certain rare exceptions in inflammatory bowel disease settings where there are prescription probiotics that I think are better quality. But there have been a lot of studies attempting to recover live bacteria from commercially available probiotics, and that you can't recover them. They're dead. With respect to vitamins, I mean, your team is probably monitoring all of the fat-soluble vitamin levels, but there are some forms of vitamins that are better absorbed. Like there's a form of liquid vitamin E, which I'll put an Amazon link in the chat in a moment. And if you get that form, which you can order on Amazon, if you give that together with the other oral vitamins, it'll improve the absorption. But Binita, you had other stuff to say while
No, and Chelsea, I think you're in the UK, which is why you're getting vitamin D injection, which is, we also have access to vitamin D injection Canada, which I think are not available in the US. So it's nice to see the global representation. I think the one thing I would say is that we used to use vitamin D injections a lot until we started using a multivitamin preparation called DEKAS, D-E-K-A-S. Some people will be aware of it. It's available across North America. This is a formulation of a multivitamin formulation that has been specifically prepared for children with cholestasis. And it has drastically reduced our use of vitamin D injections because it, first of all, it has a lot of vitamin D in it, but it has the right formulation of vitamin E, and it enhances the absorption of vitamin D. So I highly recommend that if it is available. I have no stocks in the company, but I will tell you that that particular preparation was developed with input from Dr. Sokol, who is one of the leaders in our field and particularly has an interest in fat soluble vitamins. So I strongly recommend that. And it could actually reduce the need for some of these injections because, Chelsea, that's hard if your son is needing vitamin D and vitamin E injections. That's not pleasant, I'm sure.
Okay, one more question. Does a liver have an expiration? Once they have a liver transplant, is there any, should there be any fear that that's not going to take them to the end of their life?
Liz used to have a great story that she told me about livers in comparison to hearts and kidneys. But I've never been able to find a paper that supported that, Liz. So I can.
Marcus Grompi, it's mice. And it's about taking cells, liver cells from one young mouse animal and using them to repopulate the liver of an animal with basically with acute liver failure that you've caused by poisoning it. And then those cells will repopulate the liver. That mouse can live its whole life. Then you can collect those cells again and do the same thing over and over and over. So basically those liver cells can live multiple full lifetimes, you know, which for a mouse is 2 years. And he did that with generations and generations of mice until he got sick of it. But Marcus Grompi was the author. It's a pretty old paper by now. But it's a great question. I mean, we know that both hearts and kidneys, when they're transplanted, you know, if a few cells die here and there from a virus or a rejection, like you don't get them back. But with the liver, because of its powers of regeneration, if you have some mild liver injury, probably those cells grow back, and it appears that the liver has a much longer half-life, if you will, than any of the other organs. But what the limit is, we don't know. I mean, there are some of the earliest liver transplants were done in the 1960s and 70s. There were few survivors, but there are a few survivors even from then. And certainly there's many survivors from the early 90s and late 80s even. So, you know, higher percentage than there would be from kidneys and hearts. And obviously we have people who are 80 years old who had a transplant 20 or 25 years ago, but we don't have anyone who's 80 who had a transplant as an infant, because 80 years ago that wasn't an option. So I'm optimistic, but I'm an optimistic person. You know, probably there will be some issues, and that's why we're monitoring people. And even kids who come off immune suppression, they're annoyed, but they have to have labs done, you know, every 3 months, just like everyone else. And we don't really know the answer, but like I said, I think there's good reason to be optimistic, but we don't know the answer. Or at least I don't know.
And they once did a half-life study using, you know, UNOS on pediatric liver transplants and found the half-life was, you know, on average 14 years. But I think that really figures into when we're considering transition to adulthood and the compliance issues that can come with that graft loss that may come with that might be contributing to that number of 14.
Well, I thank you all so much for coming on this live Zoom. It's such a wonderful opportunity, and we look forward to having each of you on again in the upcoming future. Transplant and Alagille is such a you know, very touched on topic in our support groups, and as you all know, it's a very scary time for families, but it's also just such a joyous time. It's a little emotional roller coaster with this, and we see a lot of questions about that. So thank you so much for coming on. Dr. Rand, Dr. Kamath, Dr. Hsu, Dr. Superina, thank you. I'd also like to thank Jen Lau from Split. I would like to, Jen, for you to just talk a minute about Split and about your patient family group that you have there, and then we'll close. Thank you, guys.
Okay, thanks. I just want to thank you again, Roberta. This has been amazing for your group and for our group with children who have Alagille's liver disease. And, you know, the group that I represent, which is the Patient and Family Engaged Partners of Split, we are a parent group who really just support our families who have gone through pre-transplant, post-transplant. We are there in advocacy. We are there in to help support in resources and just really be there for families. We're the group that's been there and done that, and so we can really you know, as a group and as a team of parents, just be together and really help take the hand of another parent who, you know, there's just some really unknown, you know, some unknowns during their journey, right? And so we're that voice to be there for them when they need it. So it's been an honor to be able to be a part of that group, and also to be able to help in collaboration with organizations like yours to be able to continue to educate and be there for many families within liver disease.
Thank you, Jen. If anyone has any further questions or would like to get answers to some follow-up questions as well, please feel free to email me, roberta@alagille.org. That's roberta@alagille.org. And I will follow up with Dr. Hsu, Dr. Rand, Dr. Kamath, and Dr. Superina. Thank you all so much for coming.
Thank you.
Thank you.